is a session on treating depression, diagnosis, and treatment choices. My name is Bowen Chung. I'm a child psychiatrist by training, so I see adults and children. I work at Harbor as well as at Rand, and I'm a part of this study.
And all of you have met me earlier today when I was talking on the collaborative care panel. So my name is Michael Ong, and I'm a general internist, and I practice at UCLA. And I'm also working on the study as well. So we thought that it would be good for us just to get a general sense of the kinds of people who are in our room and what sort of issues you are also interested in. We have here some slides that talk about the process of assessment as well as treatment choices, and primarily we're going to be talking about medications, but there are two different paths in terms of treating depression, one being medication and the other being psychotherapy. And I think that it's also important to recognize what our clients or patients are most interested in, because not one treatment is not going to fit everybody, and we want to make sure that we find the right kind of treatment for our clients. So anyways, just to go ahead and get started, we just wanted to sort of run through what we see usually for any type of initial visit. And so usually within an initial visit for any type of provider, we're interested in, first of all, making sure that the person is coming in, if we're talking about depression, how depressed are they, and how can we do that? And I understand that several people in here have mentioned that they've used standardized screening tools, for example, like the PHQ-9. Somebody else earlier today had mentioned the Beck Depression Inventory Scale. So there are many different types of standardized approaches that are out there, and we'll talk about one of them, the PHQ-9, which stands for the Patient Health Questionnaire. And we'll go through each of those questions for you. We'll also talk about education. We'll talk about treatment options. And then we'll talk a little bit about, starting up an initial treatment plan, some of the issues around that. And, the main thing that happens is that in any kind of visit, the biggest thing is not only just talking about the treatment options and starting up the treatment plan, but really coming up with a plan for follow-up to make sure that they're going to come back in, whether you're going to talk to them in person or by phone or have somebody else help you out with that. And we really want them to come back in about a week to really check in. And part of that comes down to one of the issues that was raised earlier about potential side effects with medications. If you're going to start up with something, what is going to happen? What are you going to feel like? And at some point, all patients are going to have these sort of questions. They need to have these sort of things answered. And then the final thing is making sure that we document the initial visit so that we know what happened, because as we all know in our busy practices, what happened 1 week ago we're going to forget. So it's always important to make sure that we document what we talked about and what our plans have been. So just to make sure that we're all on the same page, we just wanted to make sure that we talk a little bit about the different types of depression symptoms. And so usually when we're talking about depression symptoms, we're talking about people who have a depressed mood and or loss of interest or pleasure. And so sometimes you'll hear the clinical term anhedonia, but what that really just means is that they have a loss of interest in their typical activities that they used to do for fun, that they found enjoyable. And then there are also some physical and vegetative symptoms that go along with depression, and we'll also talk a little bit about some of these physical and vegetative signs. And then we'll also talk about thoughts of death or suicide and what you might hear from a patient if they're thinking about these sort of thoughts. So when we talk about depressed mood or anhedonia or loss of interest or pleasure, these are the sort of terms that you'll get from a patient. They'll tell you that they're sad, that they're feeling tearful, that they're feeling guilty about certain experiences, that they're pessimistic, that they have this sense of failure, self-dislike, dissatisfaction, irritability, social withdrawal, self-harm, apathy, or, again, lack of pleasurable activities. I'm sure we have all met a patient that has these symptoms. In terms of physical or vegetative symptoms that you'll see for patients who have depression, they might tell you that they're having trouble sleeping or that they might be sleeping too much. So it's actually on both sides of that spectrum. So it's not just one side of that. This also includes early morning awakening. They often will tell you that they're having trouble concentrating, that they have decreased energy, that they might have decreased sexual interest, loss of appetite, or again, sometimes they'll move to that other side of the spectrum where they're actually overeating instead of having that loss of appetite. They might mention that they're having digestive problems, constipation, bowel irregularities, or aches and pains. And oftentimes for patients who are coming from different backgrounds, who are not necessarily born in the United States, they often will talk about these physical symptoms a lot more than telling you that I'm feeling depressed. So it's really important when we start hearing about some of these physical ailments, when we hear more complaints about that, we want to make sure that we actually also investigate and see whether or not they really are depressed. Just some other signs that might also show up in terms of patients being depressed. They might have a disheveled appearance, compared to what they normally would look like. They might have difficulty sitting still. In other words, they might be restless. Or, on the other hand, they may also have slowed speech or slowed movements or also reactions. And then finally, you always want to make sure that if you're thinking that somebody is depressed, you really want to find out if they have thoughts of death or of hurting themselves, and you also want to find out if they've ever tried it before, if they've ever actually attempted suicide, and if they have any sort of current plans about that. So I don't know, Bowen, if you wanted to talk more about this or not. I mean, I can certainly go through it.
This talk was originally actually designed for primary care physicians who aren't, and most people here have a strong mental health background. So I think everybody here feels comfortable with talking about these things. Am I right? Yeah.
Okay.
Oh, sorry. So that's why the talk was framed this way. I think the only two things that I would add is for older people, or even other people, they'll say they're bored. Apathy translates into I'm not interested in anything. I'm really bored. Nothing seems fun. So that's what anhedonia looks like. Just to go through suicidality, everybody feels comfortable talking with their patients about suicidality, right? Does everybody feel? I'm never quite comfortable, but I mean, I know how to do it now. Everybody feels comfortable? You guys in the back feel comfortable? Okay.
I don't.
You don't? Well, Peter, yeah, we can talk about it later.
Okay.
One of the things you want to ask people who are depressed, obviously, we'll go through this very quickly. Do you feel like hurting yourself? Have you had any accidents in the last month or two? And in those accidents, did you mean to actually run into that tree? Especially for men. You want to assess any current plans, because a lot of people walk around with suicidality, like, all the time, right? So, or they think about death all the time.
One of my providers actually had me write a no-suicide contract. We've never used it, but, if the provider feels that this patient might be suicidal.
I mean, we do that, go through suicide contracts with patients.
Okay. So does it work for you?
The evidence actually, this is going a little away from the talk, the evidence on suicide contracts is actually pretty equivocal, meaning that it's not clear that it necessarily works, at least in the studies that I've seen. So, but I don't think it's a bad thing to do. I think just because it's not clear that it does work doesn't mean that it doesn't, but I think it's a reasonable thing to do. Go to the next slide. If we go through the previous slide, you just want to look at prior attempts. You want to look at hopelessness. Older males who are living alone, especially if they drink, really they're at high risk. People with anxiety disorders, so if you have panic and people's really worried and nervous with depression, they're also at high risk. People who have things like cancer or may have just had a heart attack, potentially terminal illnesses, they're also at risk as well. So I want to go down. Diagnosing depression. So you want to figure out whether people meet criteria for depression, meet criteria for dysthymia, which is kind of a minor depression. What if patients meet neither criteria? What do you do then? For major depression, you want to have the symptoms of depression. You want to have them nearly every day for 2 weeks or more. And you don't want to diagnose someone depressed if they've just lost their loved one, like a son, a daughter, a parent, a best friend. You want to give them a couple months. and also if there's mania. Let's see. You want to have 5 or 9. You want to have 5 or more of the 9 symptoms. You can have either the depressed mood or anhedonia, because not everybody knows what depressed mood is. I think minorities, men, they don't talk about feelings. We don't talk about our feelings, but they do talk about boredom or being angry. And then you want some of the other symptoms on the left-hand side, like weight changes, the energy changes, the fatigue, worthlessness, guilt, thoughts of death, concentration. Anyway, and I'll turn it back over to Mike.
That are out there, and so it's not as though you have to use the PHQ-9, but that's one that has become more readily accepted, and it actually goes through all those different symptoms that we had talked about in terms of depression. So it's a 9-item self-administered questionnaire, so you can actually give it to the patients and they can fill it out on their own, and it is also available in multiple languages. So primarily for the groups here in Hollywood, we would want to make sure that it's available in Spanish, and it is. So that's something that you can download from the internet if you wanted to find it. So it closely follows the DSM-4 criteria for depression, and it's been validated not only for diagnostic assessment, so not only for identifying depression, but it's also been validated in terms of following up patients and seeing, are they getting better or are they getting worse? And that's really important in terms of seeing how our patients are doing as they come in over time. And as I mentioned, it's available online. You could just Google the words PHQ-9, and usually the first or second term is going to be the actual PHQ-9 instrument itself. And I just happened to put on here one of the websites that it's available at, since the Pfizer company was underwrote the development of the PHQ-9.
Can I just address something that
Sure.
I've seen in our community is that, this is where I question the PHQ-9, but, one patient you just made a statement, it tells us if the condition is getting worse or not. And what I'm starting to see is just really there's high lows, and, a patient comes in and says, I'm feeling fine, and then they have a stressor the following day, they're completely, the PHQ-9 scores are much higher. And that's the challenge that I'm having in working with my patients, is really having them understand how to complete the form, really understanding the 2-week piece. But I don't know if you guys have had this experience or anyone else, but I guess I'm wanting feedback as to how to address that.
So just for the camera purposes, just to sort of summarize, the comment was that with using this instrument, the PHQ-9, sometimes we see that people's scores on on a given day is might seem okay, and then all of a sudden 3 or 4 days later something bad happens. They max out on the scale, and then it sort of comes back down again. And what do we do about these sort of different numbers that we keep seeing? And I think that the main thing to keep in mind is that this is tracking symptoms. Certainly there are going to be changes that happen from time to time, particularly as stressors happen. So I certainly have experienced the same sort of thing when I've used the PHQ-9 in terms of administering it to patients. I think that the main thing that you want to see is a trend. Are they getting better? And we know that there are going to be blips that happen when experiences such as what you mentioned. If something bad really happens, somebody loses their job. Let's say somebody close to them dies. We know that that is going to add additional stresses. It's going to make the situation much worse, and of course they're going to be feeling every day a lot of these same symptoms. But I think that as we're tracking people over time, we do see that there is going to be some variability, but overall, if let's say that we're treating them with psychotherapy or we're treating them with medications, we would want to see overall accounting for those blips that happen, and we want to make sure that we can explain them. But if we see that the trend is getting better, we could probably infer from that overall it seems like they're doing better. Now, on the other hand, if the trajectory keeps getting worse, that would probably suggest that what we're doing right now may not be working, and that we may need to change or augment the kind of treatments that we're providing for our patients.
And when you're tracking changes, are you tracking them on a monthly basis, week? What seems to be the trend?
So I think that this varies across, how frequently people come in. I think that initially, it makes sense every time that you have a contact with a patient that you would want to see how they're doing. I think that once people become a little bit more stable, you can certainly track it on a monthly basis if that makes sense for the patient and if they can do it. I think that once people are doing a lot better and you're in, let's say, just tracking to make sure that they're not getting worse, that they're sort of in this maintenance phase of treatment, I think at that point you could probably space it out to every couple of months, depending on how frequently they're coming in. And again, for the kinds of patients that we're often working with, it's not easy for them to get over to where we are. So I think that it might be helpful in terms of not only doing it when they come in, but potentially also if somebody's outreaching to them or having them do it at home, because again, this is something that can be self-administered, so they can also recognize on their own, I know my symptoms are getting worse, I need help, I need to come in. So how many people have seen the PHQ-9? Nobody can read this slide from back there. So, is anybody in here unfamiliar with using this PHQ-9? Okay. So I think that this is in the handouts. But again, what I would just say is that. Just to briefly go through it, what it asks is, over the last 2 weeks, how often have you been bothered by any of the following problems? And those 9 things that we talked about earlier are actually each on here. Little interest or pleasure in doing things, feeling down, depressed or hopeless, trouble falling or staying asleep or sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself or that you're a failure or you've let your own family down, yourself or your family down, trouble concentrating on things such as you're reading the newspaper or watching television, moving or speaking so slowly that other people notice it, or the opposite, being so fidgety or restless that you've been moving around a lot, much more than usual, and then thoughts that you would be better off dead or hurting yourself in some way. So again, these are all those same sort of symptoms that we talked about earlier. Now, what it asks, as I mentioned, is over the last 2 weeks, how often have you been bothered by these symptoms? And there are 4 different breakdowns in terms of how frequently this is happening. And so there's a column here that says not at all, which scores as a 0, several days out of the past 2 weeks, which scores as a 1, more than half of the days, which scores as 2, and then nearly every day, which scores as 3. And I think the next slide shows an example of what might happen if somebody fills this out. So this individual goes through the PHQ-9 and says, when I look at this question about over the last 2 weeks, how often have I been bothered by any of these problems, they think, so the first question is little interest or pleasure in doing things. And if the person feels like it's been happening more than half of the days, they put a little check in here, and this signifies a 2 on the score. And what we do is we go through each of these lines, and at the very end, we total up the sums. So in here, it's a total of 15 after they've gone through all of these. And then, as we talked about from the earlier comment, if somebody's really depressed, they're just going to mark off everything here on nearly every day. They often, I often see patients go through this, and they just kind of just scroll through it as fast as possible, and you know that things are just bad. And I don't think that you necessarily need to treat the number per se. I mean, I think by that point you kind of get a sense that things are not going so well. So it is helpful in terms of having a number to get a sense of where patients are, but I think that as we work with patients, we also have that same sort of sense too. This is just another way of us being able to identify that if we're not totally sure. But in terms of breaking it down, there are different categories in terms of, if somebody's numbers on the PHQ-9 screen fall into a certain range, it gives us a general sense of where they might be if they are depressed. So, for example, somebody who scores 1 to 4, probably doesn't have depression, or at best minimal depression. If somebody scores 5 through 9, we would call that being mildly depressed. If somebody's scoring 10 to 14 on this, we would say that's moderate depression. Somebody scoring 15 to 19 would be moderately severe depression. So just like that example from the prior slide, that person scored a 15. We would say that person might be moderately severe depressed. And anybody scoring over a 20 would be considered severely depressed. And again, I would treat the PHQ-9 as a guide because, as we mentioned before, there were some situations where people's scores may be very different. And particularly, as we mentioned in terms of thinking about depression, if somebody is having some type of inciting event or something that happens to them, such as like the passage of a loved one, that's going to change things dramatically. Or, for example, if we're seeing somebody for the first time, but we know that not only are they having these really deep periods of depression, but they also are having periods where they have way too much energy, much more than what we would expect from a normal person, where you hear that they are staying up 72 hours, running around, doing all sorts of crazy things. It probably would suggest a different type of diagnosis, such as bipolar depression, that may not necessarily be treated the same way that we would treat somebody who is only suffering from major depression. So maybe this is a...
Oh, yeah. Let's see, cultural differences. Well, we went over this. Everybody knows, especially in LA, that men and I think ethnic minorities. I used to work with Korean Americans. I'm Korean American. I used to work with Korean Americans for like 7 years, and a lot of especially the elderly, would come and they would never say they were depressed. They always had like symptoms like they felt tired, their chest was tight, they had trouble breathing, they had headaches, and then they endorsed all these other symptoms, right? So there are a lot of cultural differences, and I think in first-generation Latino populations, it's also true. I've noticed that with Armenian populations. I think essentially non-sort of white Western seems to change over second generation and third generation. So, dysthymia is also something. Chronic depression is also something that's a big concern too. People with chronic dysthymia are people who may not necessarily meet criteria for major depression. It's less symptoms, but it goes on for a really long time, like years. And I think that's what the criteria for dysthymia would describe. And I think everybody knows people like that, whether personally or professionally in your clients. People just have a very negative outlook on life. Let's see. I want to go next one. For dysthymia, you just want two or more of the symptoms for the diagnosis. Loss of self-esteem, the insomnia, hypersomnia, feelings of hopelessness, poor concentration, low energy or fatigue, poor appetite or overeating. You want it to go on for 2 years or more. So, bereavement, everybody's known somebody or probably has experienced a loss on their own. And a lot of people will come in and they'll score like a 27 the day after their loved one has died, right? But they may not be depressed, in the sense that they don't. This is the one special category where you're not necessarily going to diagnose someone with depression. They can become depressed over time. And usually what you see with people with bereavement is that over the a couple weeks they'll actually improve quite dramatically. What happens is with the people who end up where the bereavement turns into depression, you'll start seeing a lot of the anhedonia, the sleep, and a lot of it. I think the benefits of for the people who don't go from bereavement to depression, what happens is they're not able to reframe the illness into sort of like life's, one of life's natural events, and reframe their relationship. So what happens with that? Let's see. Adjustment disorder. So adjustment disorder applies to everybody. Just people don't meet criteria for major depression, dysthymia, bereavement, or other major affective mental disorders. People may have emotional symptoms out of proportion to what might be experienced. So, for example, with a financial crisis. I think that when people lose their jobs, a lot of people will get really upset for a period of time. Some of this will lead to depression. Some people will adjust to, and it'll sort of work itself out. Like they'll find another job, or they'll reframe things and get things together and say, "Hey, you know what? This isn't. I can work through this." The symptoms might start within 3 months of the stressor, so sometimes there's a delayed reaction. Let's see, adjustment disorder, patient education. Oh, patient education. So everybody should know that, you know, depression affects everything about a person. It's very physical, right? And actually, if you talk to people with chronic depression, they can describe what we like to call in medicine a prodrome. People can describe when depression starts coming on, especially if they've had multiple episodes. You get less energy, focus and concentration start going. You know people who are depressed because they carry themselves differently, right? Their head goes down, right? They can't smile. The facial features are drooping. If they're really depressed, they hang their shoulders, right? Maybe they're not as well dressed. They may have lost weight. Their clothes are baggy, or they may have put on a lot of weight. So it's a very physical thing. There's a cycle of depression model, which we'll show later, which talks about, you know, sort of the cycle of depression that can take place with different stressors in one's life. Depression is the one cool thing about depression, which I think is, and this is why we're doing the medication, it's treatable. You know, I think with therapy and medications, for the most part, people get better. And that's actually quite a remarkable thing. Even more than a lot of other chronic illnesses. And that's actually what makes it rewarding for me as a psychiatrist to work and treat in depression, because a lot of people get much, much better with very simple interventions. As I said, depression recovery is the rule, not the exception. But, you know, people can relapse, you know, even after being well for a long time. Things like alcohol, or things like Xanax, or things like, you know, benzodiazepines especially can make things worse. I think among young adults right now, marijuana is a big thing, right? Because they can go to any pharmacy and get it, one of those medical marijuana pharmacies. So I see a lot of people who have depression induced by marijuana. So lots of things can make it work, including relationships in the financial crisis right now.
Yeah, so the other thing that I would just also mention on this is that, you know, when people go to their primary care physician and they start complaining about some of these problems, I have aches and pains, I'm having trouble sleeping, they're going to give them something like a minor tranquilizer, which is going to be like benzodiazepine or Xanax or something like that, which is probably going to make the situation worse. And so that's the reason why we think it's really important not only for you know, the primary care physicians to get a better understanding of depression to make sure that they're also diagnosing it, but also for us working out in the community to make sure that, you know, people that we're working with actually understand what they're really experiencing, so that, you know, when they go see a physician, they're not necessarily going to be given something that might potentially make things worse.
Our patients that can't sleep, we give them Elavil.
So, yeah, so the question is about using Elavil. And so Elavil or amitriptyline is actually one of the original antidepressants. So it can be used in terms of helping patients sleep. And we also, and as we'll probably, I think later on in the talk there are some other examples of when it might be okay to use a sleeping agent with other antidepressants. I think that the main thing is that you don't want to give this alone. You want to make sure that you're giving some type of appropriate treatment if you're using medications. So with antidepressants, we know that amitriptyline has antihistamine effects, which are going to make people, you know, go to sleep, just like if we're going to give somebody Benadryl, like if we're taking it for a cough or a cold. If we're taking antihistamines, we often will feel sleepy with it. So these things are helpful at low doses, and then also if we're using it at the higher doses, which are more appropriate for treating depression, amitriptyline would be a reasonable choice. The one reason why we don't use amitriptyline as often these days in terms of treating depression is because we have other medications that have better side effect profiles than amitriptyline, and particularly in the elderly, amitriptyline does not necessarily work out so well, particularly for those people who have incontinence problems, or again, you know, might be affected much more strongly by some of the side effects that happen with amitriptyline.
The other one is the risk of
That's right, and the risk of overdose as well. So the one other thing that comes up with using some of these older medications is that it can actually affect the cardiac rhythms in your heart. So if you're taking high levels, it actually can interrupt your heartbeats, and so that can lead to sudden death. And so, you know, this again, you know, while it's a medication that we would normally use to, you know, work on depression and also to prevent suicides, I mean, at some point, if somebody's overdosing on these medications, it can lead to a very bad situation. So this is the cycle of depression. And so as you can see here, we think about depression as being in the center of this, and you can see that there are all sorts of different things that potentially could affect depression. So there are stressors such as medical illnesses, family problems, work problems. These are all things that our patients are experiencing. And that when they have these stressors, these can lead to these sort of negative thoughts in terms of thoughts and feelings, low self-esteem, sadness, hopelessness. And it can also lead to physical problems in terms of poor sleep or pain, low energy, or poor concentrations. And then these lead to other types of behaviors that we start noticing among our patients or clients in terms of social withdrawal, decreased activity, and decreased productivity. And so at some point, these all sort of cycle back through again, so you can see that these are sort of bi-directional arrows. So when people are experiencing these same sort of behaviors, this sort of feedback upon itself and becomes a sort of negative feedback cycle, and it just gets worse and worse. So on one hand, when we talk about people feeling down, I mean, we all feel down at some point. We all have experiences that might make us, feel unhappy or sad. But at some point, when things get pushed over to a point where it moves into this negative feedback cycle and things just get continually worse and things don't improve, that's when we have to start thinking, are we moving more towards depression? And that's the reason why we thought it was important to make sure that we talk about some of these other conditions like bereavement or adjustment disorder, because we know that there are events that can happen for all of us that might make us feel down, but it wouldn't necessarily make us depressed. At some point, if things continue to persist and are severe enough, at some point, we would want people to seek treatment. So, talking with caregivers about depression. So, not only should we be talking to our patients, but the thing is that patients are embedded in social structures, and we know that not only do we need to talk to our patients, but we also need to talk to other people who are working with them, who are caring for them, and particularly in the example of the elderly who are homebound, people who are providing care for them too. So there are certainly patient education materials such as booklets and videos, and we had some of the booklets back in the back that you now have that can aid caregivers in terms of recognizing some of these depression symptoms. In addition, caregivers may have a better view in terms of the patient's moods and some behaviors and changes over time. We only see what happens to clients or patients when they come into the office, but we won't really know what's happening at home. And so for that reason, it's really important to try to recruit everybody to focus on this. The final thing is that is something that we had mentioned earlier in terms of looking at some of these symptoms. Common symptom for depression among men is irritability or anger. So in terms of supporting antidepressant management, it's important to make sure that we're familiar with the commonly used antidepressants and their medication dosages. We also want to make sure that we're providing basic patient education about antidepressants. We also want to make sure that patients continue to take their medications, because probably the biggest thing, after starting patients on treatment is that usually patients stop. And we want to make sure that patients continue on with their treatment, because if they continue on with it, they'll get better. And then finally, it's important for us to know when treatment isn't working and when we have to make a change.
Will you be discussing that?
Yes.
Absolutely.
So the other things that we want to make sure is that we want patients and providers to know when we're using inadequate doses, because we oftentimes will start medications at low doses so that they get used to it, and then we'll slowly ramp it up. But oftentimes what happens is patient gets started on a medication at a low dose, often in the elderly because we're concerned about side effects, and they stay at those low doses, and the medication never changes. And they're taking these low doses that aren't helping them, but they're continuing to take them. The other thing is ineffective treatment in terms of making, we know that, there can be persistent depression after an adequate duration of so even after we try an antidepressant, it might not necessarily work, and we need to make sure that we understand, is this really working? Do we need to continue the treatment longer? We shouldn't just stop the treatment just because we think that, there's a certain set time period that medication should be effective, and at that point we can stop. There are also side effects that we also want to be aware of. And then we also want to make sure that we really help doctors and other types of providers work with their patients in terms of talking about the problems with their antidepressant medications. Because oftentimes, as I mentioned earlier, when a patient goes into a doctor's office, if they have 10 minutes with the doctor, this might not come up. If they're going to talk about 5 issues, this might be issue number 4. They might not get to it, and so we want to make sure that at some point, if somebody's prescribing the medications and there are some problems with it, we want to make sure that they're aware of it so that they can change course if it's needed. And then finally, if there are additional problems, particularly with the way that we use the collaborative care model, there's always backup for providers. And so a common complaint that we hear from primary care physicians is that they're uncomfortable with, what happens if we run into complications, what if people are not responding. There's always somebody that you can tap into. And I think that with the collaborative care model, not only, do we have the whole team, working with a primary care doctor, working with a therapist, working with the case manager, but we also have, additional backup steps in terms of having somebody there like a psychiatrist who can, work with those cases where things don't seem to be working under the initial regimens that we suggest. And then the final things are the main principles of using medications. It's ideal if we're using antidepressants and not these sort of minor tranquilizers like benzodiazepines. Now, it is certainly reasonable initially, because some of these antidepressants take a little while to kick in, to maybe use something to help patients, while they're experiencing problems of sleeping, or problems with sleep. So if they're having insomnia, in that case, it might be okay to use some type of an agent to help them sleep for a short while until the medication starts kicking in terms of these other types of antidepressants. But we wouldn't want to continue them on, and we wouldn't want the minor tranquilizer or things like that to be the only treatment that we're providing for them.
When you say initially, what do you mean by that?
So usually in about the first 6 weeks or so, 4 to 6 weeks would be appropriate. So so the main type of medication that we'll be talking about are these SSRIs, or serotonin selective reuptake inhibitors. And so we know that some patients will respond very quickly to them, but for the most part, we see people responding sort of about 4 to 6 weeks after getting appropriate doses. And during that time, while we're waiting for those effects to really kick in, they might still be experiencing sleeping problems, and it might severely affect their daily routine. So, if somebody's having insomnia problems, and they're just fatigued all the time at work, well, we need to do something in the interim. We don't want to wait until 4 to 6 weeks when the medications start working. So at that point, it would certainly be appropriate to use something else to help with that. But at some point, when the medications are working, they shouldn't need that anymore. We want to make sure that we're using adequate doses for an adequate amount of time, and we'll talk about that. And then we also want to start slow and work with side effects, but we also want to make sure that we're increasing the doses so that we get to an effective dose, because otherwise we're just going to be stuck at that same low level. And then the final thing is that if it's not working, at some point we just have to say, okay, this is sort of the time point, we've got to switch course. This is, you don't want to continue on ineffective therapies. And so usually after about 8 to 10 weeks, at that point, if there really hasn't been much of a change, at that point, it would be reasonable to try a different type of medication or to try a different modality of treatment.
I'm going to make a quick point about this. He did a really nice job of explaining it. The big mistake that primary care physicians make is inadequate dose for an inadequate amount of time. So one clear example, and we'll go through the dosages later, is, so for, I don't know if people are familiar with Prozac, but it goes from 0 to 60 milligrams. And they'll say it's ineffective even though it's been on 10 milligrams for 6 weeks, right? And that's a big problem. So you want to make sure, and actually the person who ends up, I think a lot of primary care physicians, except for Michael because he's a super primary care physician, most of them, I think a lot of who are just not as trained, they haven't been trained it properly. They rely on the social workers and psychologists to really help them out and figure out what to do with this. It's reasonable to go up on the medications fairly aggressively if the person doesn't have side effects.
Which takes me back to my earlier question. How does the patient know when this medication is working? Because here you have the tranquilizers, the minimum, and then you're having the transition of antidepressants, which can take into effect, from 4 to 6 weeks. So how does the patient realize? I mean, I know, but how does the patient begin to understand that they still have these life stressors, right? And it's working now.
Well, what I often have found when I've been working with patients who are taking antidepressants and going through depression, they often come to the sort of realization, things are not as bad. I'm able to cope with things better. It's not all the way better, but I'm able to cope. And before, when they first come in, they're just a mess. There's all sorts of problems going on. They're just not sure where to even begin. And so I think that once you start seeing that change, that starts suggesting that things are getting better. The other thing I would mention is that what Bowen mentioned is something I see all the time. Doesn't matter what clinic I work in. I see patients who are on Paxil paroxetine, 10 milligrams. And what often happens is the doctor who has come in to take care of that patient will say, well, I'm coming in to take care of this patient for the first time. They've been on these medications for a while. We'll just continue them. Things seem to be going okay. Of course, they never really ask about depression, or get a sense of how bad things are really going. But they just tend to continue on what they've seen people use before, and they feel very uncomfortable about changing something unless they see something tangible that they feel comfortable about. So, for example, with blood pressure, if they see that the patient's blood pressure is now a number that they are familiar with, instead of being 120 over 80, they see a number that is 180 over 100, they'll say, okay, maybe I need to make a change. With depression, when people feel uncomfortable about it or is not as familiar with it, if there's not something that, for example, a doctor may say, I can hang my hat on saying that there is this certain threshold where I know that, yeah, they're having symptoms, but it's gotten worse. Should I make a change in the medication? Usually with primary care providers who are less familiar with using some of these standardized instruments, they'll just sort of say, well, seems like, I'm a little unsure. I don't really want to change course. I might make things worse. We'll just leave it as is. And again, that's what we don't want to have happen. So by using something like the PHQ-9, it provides something that makes a provider a little bit more comfortable in terms of saying, well, symptoms have changed. I can really see that, before this patient, when they did this PHQ-9, their numbers were, let's say, 10. And, now these numbers are 20. Seems like something is different, something is wrong, and I need to do something different. And and if they're on these medications, they could certainly increase the dose.
Yeah. And the other thing is that the PHQ-9 score, especially if you keep track of them, they're nice because people forget how they answered 3 weeks ago, so people can look at it. And some places will even graph it out. So I think that that's a nice way to sort of convince people, because it's interesting. I mean, because with depression, actually mood's less. Your self-perception of how you're doing is actually the last thing to change in general on these things. So people will move better, they'll function better, they'll sleep better, but their perception of how they're doing is not as good. Is the last thing to change. So we'll go to the. So it's good to actually. There are a lot of really. There's a lot of choices with antidepressants, and that's a wonderful thing. So everybody's familiar with the SSRIs, the serotonin-specific reuptake inhibitors. They've been around for a long time. I think like 1980, so we're getting close to 30 years, right, with Prozac. Fluoxetine, paroxetine. I'm just going to go through the generics. Citalopram or Celexa, sertraline or Zoloft, fluvoxamine, Luvox. There's also now Lexapro or escitalopram, which is still on patent. There's the newer antidepressants. Well, they're actually not so new anymore, like Wellbutrin or bupropion, mirtazapine or Remeron, venlafaxine or Effexor, or duloxetine and Cymbalta. And then there are tricyclics, like imipramine, doxepin, dizipramine, imipramine, right? So everybody knows these things. The TCAs aren't actually recommended for older adults, and actually I think most people will stick to the SSRIs or the newer antidepressants. Just one thing about these medications that I'll mention is that a lot of these medications, and this is good for people to know because once the doctor prescribes it or making suggestions, is that a lot of them are actually available as generics now. And I think that this has really lowered the access. But I work at Harbor, and I work with a lot of people who don't have phones or homes. And, some of them don't have insurance, and the county won't pay for the medications. And even a homeless person can figure out how to get $4 a month for some of the prescriptions out there, like at Target, Costco, Walmart, Ralph's. And you can get fluoxetine a month supply for $4. So it's pretty remarkable, or citalopram even. depending on the pharmacy, they'll have different options. Wellbutrin even. So all the antidepressants have similar effectiveness, about 30 to 40% response, and actually it's a little bit lower than we used to think. We just have results from a major study called STAR-D, which is a big national study on antidepressant effectiveness, and they sort of said it was about 30 to 40% for first try. You usually get a response in about 6 to 8 weeks, meaning that, if you titrate up these medications, meaning I think for something like fluoxetine, probably like 20 milligrams or 40 milligrams would be a good dose. In 6 to 8 weeks, you should see some response. There's reasonable amounts of discontinuation rates, and I actually don't remember what those were because in the STAR-D, but there are side effects, so people do have side effects and the medication will stop it. I think common side effects include the nausea, feeling kind of out of it, foggy. A lot of people feel foggy, tired. Sexual side effects bother a lot of people. I think about half of people have that. There are several ways to work with those side effects, and actually we'll go over them later.
What is the best time to have them take the medication, morning or night?
It really depends. There's no right answer for that. It depends on the medication, and it depends on an individual's own response. So even with the different SSRIs, it can be a little bit different for different individuals. It's hard to give a blanket statement.
We have pharmacists at Princeton, and they actually recommend that patients take them in the morning.
It's like I said, I think that if you see people and actually ask them about their side, at least I know what pharmacists say, but I don't think there's any rule for this. I think that in general, you just want to make sure that you listen to them, and I always say, you give it a shot. Take it in the morning, see how it works for you. Next week, take it in the afternoon, see how it works for you. Take it in the evening, see how it works for you, and then write it down and we'll figure it out.
The other thing I would also add is that as long as the patient remembers to take the medication, that's the most important thing. So I think that's the main reason why pharmacists tend to suggest taking it in the morning. Now, certainly there are some that, there are some that are more activating. There are some that are going to make people a little bit more sleepy. So, there are going to be differences for them. But the most important thing is that they take the medicine.
That's right. Yeah, he makes a great point because half people who say they're taking them aren't taking them.
We actually, they come in with their bottles, and we actually count them.
Yeah, well, they can if they want to be good patients, they can do. I had a Korean American patient, a woman who was 72, that I treated for 3 years at Asian Pacific Counseling Center, and she would come every month religiously to my appointment. She said she was taking her medications, and about 2.5 years into treatment, her children came one day with her, and they literally brought 3 boxes of medication. She never took a single thing, and then actually at the appointment, what the children said, I said, well, it's really confusing because she's been coming to see me for 3 years now, every month. She never misses a point. She'd bring me socks on Christmas and cologne, right? And it turned out that she really wanted. Her children never came to visit her, and I reminded her of her children. Isn't that interesting? So you can never actually. There's lots of different motivations for people to come. So that was the most striking story that I.
So in a sense, that was more effective than.
Well, it was effective for the day. Yeah, it was a social networking part. Anyway. So. I don't know, how much detail do you guys want on these?
A lot.
You want a lot? Okay. I'm just curious, just because I want to see what kind of comfort level.
I want to know whether culturally, whether it has a different effect for different cultures.
Well, okay, there's two. Okay, so any other? So one question was, is there any differences between cultures or races? Any other big questions?
Yes. If they scored 20 on PHQ-9, would you start them on a higher dose?
No. So the question was, is if they had a higher score on the PHQ-9, would you start them on a higher dose? No. Okay, any other questions? Okay, and you guys want to go into excruciating detail? Okay. So these are the medications. They're actually, fluoxetine, Prozac, and the top name is the generic. The bottom name is the brand name, right? They're actually, just in terms of effectiveness, they all work roughly about the same. Right? So, you'll hear doctors or you'll hear drug reps come through. They'll say one thing's better than another. The reality is they're all pretty much the same. There are some slight differences in side effects. So, for example, something like Paxil, they say is more sedating. It's probably true. But roughly, even the side effect profiles are very similar to each other for these particular medications. Let's see. The common side effects, as everybody knows, is greater than 10% insomnia, restlessness. So people feel a little bit edgy, agitation. Sometimes people get a tremor. Sometimes people get nausea and diarrhea, which is kind of strange. Headaches, dizziness, sexual dysfunction. The one thing about the side effects is that they go away. If people over 3 to 6 months, if people get better with their depression and they're able to tolerate the side effects generally go away if people are patient. And I think just reassuring people that they tend to go away, except for maybe the sexual side effect, that doesn't go away.
You aware of any effects on people who have difficulty getting off the medication?
You mean the antidepressants?
Yes.
Well, and when you say, the question was, are there any effects of people who have difficulty? When you say difficulty getting off the medication, what do you mean by that?
Having strong side effects.
Oh, from withdrawals. Yes. So in general, with these medications, there's not a huge withdrawal effect with these particular medications because of what we call the half-life. There are other classes of medications that there are. But in general, there's differences in how people respond. So you do want to, quote unquote, titrate people off slowly, meaning you want to get them off over maybe a couple weeks or a month.
Because I've seen more difficulties with our clients who've been on Prozac, being able to.
You want to wean them off. Yeah. So Prozac, fluoxetine, you get 10 and 20 milligrams. The therapeutic dose is between 6, 10, and 60. Usual starting dose is 20 milligrams. Usual dose is 20 milligrams. You can start on 10 milligrams. It's got a long half-life, so it generally tapers itself, but some people do have withdrawal effects. It's available as a generic, so that's nice. So it's cheap. So it's $4 a month, as I like to tell people. Paroxetine or Paxil comes in more dosage forms, 10, 20, 30, 40. You can go 10 to 50 milligrams. Actually, I think that's incorrect, but you got 20 to 30 milligram usual dose. Starting dose is 10 milligrams. It has what they call histaminergic side effects, so kind of like with Elavil, the dry mouth, constipation, weight gain. Generally don't want to use it with older people. But it is also available as a generic, so that's nice. Escitalopram, this actually is not available as a generic. It's a cousin of Celexa. I like to call it Coke and Pepsi. Or Coke and Coke, Diet Coke and Coke Zero, in that they're more similar than different, and unit doses available are 5, 10, and 20. Therapeutic doses are 10 to 20. It's a very what they call a clean medication. It doesn't interact with a lot of other medications. Same with citalopram. Sertraline or Zoloft is also available as a generic. It's an older medication. The dosage is patterns are a little bit different. You have 50 and 100 milligrams. You can go down. Actually, they also have 25 milligrams, if I'm not incorrect. And you can actually go from 25 milligrams or 12.5 milligrams all the way up to 200 milligrams. Starting dose, some people say 25 milligrams, some people say 12.5 milligrams. And usual dose is anywhere from 50 to 100.
Is there any reason why you should combine, let's say, Prozac and Zoloft?
No.
So you don't combine them?
No.
What about, I've seen a lot of patients with not only depression but also anxiety. So are there any, I know, and I can't remember right now, but there was a med that was creating much more anxiety.
Sometimes people say that fluoxetine causes a little bit more anxiety. In general, all these medications have indications to treat anxiety. So they work for depression and anxiety because it's, this is not an anxiety talk, but they seem to be related. So generally when people say that it causes more anxiety, it's that restlessness, which is a little bit different. And generally the thing to do in that situation is go on to either try a lower dose or to switch to another one of these. In general, the best thing to do with things like anxiety, if people feel like that, is to just start on a much lower dose. And things like, actually, I like Prozac because it has a liquid form, and you can actually start at like 2 milligrams with people who are really anxious.
It might be worth noting, unless you already said that, I mean, these medications among the antidepressants are about the safest in an overdose situation. They're many of the antidepressants are actually not safe to overdose on, you might say, but of course people with depression can be suicidal, right? So these are the safest class of antidepressants for patients who are suicidal. Bowen, I think it's true that they're really the only class recommended for younger, for like teens and transitional age youth. You're going to go through that, and the elderly as well for safety reasons. So this is the safest class.
Yeah, there's a whole slide on side effects, but the other thing about this is, while we're here, everybody's heard about the black box warning for kids for under age 18. Some people don't know who it applies to. Now it also, this is a talk about adults, but what they've noticed is that for adults between the ages of 18 and 24, 25 roughly, that it seems there's what they call a signal where it seems to increase risk of, not risk of suicide, but increase suicidal thinking. So if you compare a group of young adults who take medication versus a group of young adults who take a sugar pill, people who are in the group that take the SSRI have an increased risk of suicidal thinking. In the group that gets the medication, it's approximately 4%. In the group that gets the placebo or the sugar pill, it's about 2%. It does double the risk. What they have shown, there's never been any completed suicides in any what they call observed situations, meaning in studies. And there is a lot of secondary evidence to suggest that it does actually decreases actual completed suicides, although studies are still ongoing. So you might want to hear about that. It's a big deal actually because the FDA issued a black box warning, which is the strongest warning they put on a medication before they pull it off the market. It was such a big controversy.
So the other thing I just wanted to mention was also about the elderly, just because that was an issue that was raised. So usually for starting doses, we are usually starting at lower doses than we would generally for adults, and that's partly because of the physiology of older individuals in terms of how they respond to these medications initially and the side effects. The other thing is that, again, many of our older patients are on multiple medications, and there definitely are going to be some interactions in terms of how these medications may affect other ones. And so for that reason, when I generally have been treating older adults, I usually will start with citalopram because, again, it tends to interact less with most of the other medications, but we often find that we need to switch the medications, and we'll try another one and see how that works for them. But usually that's the first choice that I would select. And then the other thing on top of that is that, again, it's generic, so in terms of these $4 per month formulary medications that you can get at most of the major national chains, Celexa or citalopram is one of them. So again, for those older individuals who don't have a lot of money, if they're just only getting Social Security, or if even that, given the kinds of populations we work with in Los Angeles, this is certainly a reasonable thing to start our patients off of. So in terms of the newer antidepressants, I'm not sure how much we really want to go through this, but again, there are these other medications that, again, if people are not responding to the SSRIs, there are these other ones that are out there. Many of them are not generic, so these are going to be more expensive for patients. And if you're working with some of our safety net clinics, these are not going to be on the formularies, so they're probably ones that you will not see as often among your clients or patients. Yeah, except for Effexor, because I think, but we'll talk a little bit about it. But anyways, so these are similar. These are, they also act sort of through the same type of pathways that the SSRIs work through, except that they're also acting through some of the noradrenergic systems. So these are SNRIs. And so you'll see that for venlafaxine, there are different sort of formulations for this. There is, one that's not an extended release, so it's given much more frequently. So it's given twice a day. Again, for having people remember to take the medications, that's not so easy all the time. So there is an extended release form that we often will give on a daily dosing regimen. And so you can sort of see here that this is the therapeutic dose, but again, we always generally start patients on lower doses initially. In terms of where they begin. So if this is sort of the therapeutic range between 12.5 to 150, we're usually starting people off on 25 a day. And that's twice a day, right? So if you think about it, we're usually starting on a much lower dose. And the usual dose will be somewhere around here, but again, we know that people have varying responses. So as I mentioned, there's this once daily dosing regimen. Again, some of the common side effects that we'll see here, again, are just like the same ones that we see with the SSRIs. So you'll see nausea, agitation, or insomnia. We also know that at higher doses, sometimes this will affect patients' blood pressures. So for those patients who have problems with blood pressure or other sort of cardiac problems, we tend not to use this medication. Duloxetine or Cymbalta is a very new medication. This one is not generic. Part of the reason why you might see patients on it is because there's an indication for using this with patients who have chronic pain. So this was the main thing that got this drug approved on. So for those patients who have chronic pain syndromes, you'll often see doctors using this medication. Again, it's very similar to the other SSRIs. So again, in terms of sort of the dosing ranges, it's not as unusual as, let's say, venlafaxine or Zoloft. And so you'll see that usually for the therapeutic range, it's around 40 to 60 milligrams a day, and that's usually what the usual doses will be too. And usually we will start people off on, let's say, 30 milligrams a day. In terms of side effects, these are usually going to be, again, just like what we've seen before, nausea, dry mouth, constipation, sometimes decreased appetite and fatigue, sexual dysfunction, and sweating. The one thing is that this is not a medication that you can break. So some of the other ones are actually scored so that you can break them, and again, that sometimes is going to be even more helpful for patients who have financial problems so that they can extend their medications longer. But this is one that wouldn't work. Some other newer medications, bupropion or Wellbutrin. Again, this is also available as generic. So this is a medication that you might also see other patients on if they were smoking. Many of our patients often are smokers, and this is one that is used to help with smoking cessation. So you can see that in terms of the frequency of dosing, it's a little bit more frequent. So in terms of the usual range, in terms of treating patients, sometimes we can get away with the once daily dosing with the sustained release preparation, or we might need to go to twice daily dosing. If we're using the original type of medication, we kind of have to go to either twice daily or 3 times a day dosing for this. In terms of typical side effects, this one tends to be one where people tend to have a little bit more of the insomnia and agitation problems. And there also is a risk of seizures at high doses. So particularly for those patients who have had a history of seizures, which we often will see when we're working with populations that may either have seizures because of some underlying seizure disorder or had a history of a seizure because they were withdrawing from alcohol, if they're using other substances. This is a medication that you wouldn't want to use. The one thing about it is that oftentimes when patients are having sexual dysfunction, this is the medication that we will often switch patients to because we know that there are minimal side effects with that. And then finally, Remeron, again, this is one that's not generic yet, but it also has minimal sexual side effects, so this is one that we will often try patients on as well, but because it's not generic, I'm not sure that this is one that we will see with this population. But again, in terms of dosing, we tend to use the usual dose of 15 to 30 milligrams a day. The therapeutic dose is 15 to 45 milligrams, and usually we start at a lower dose at 7.5. And then finally, in terms of the older medications, they're still effective. It's not as though you can't use them, but it's just that they tend to have more side effects. And so nortriptyline is another one that you will also see on those $4 a month formularies. So this is one where the starting dose tends to be lower in terms of starting at 10 milligrams, but the usual dose is somewhere between 50 to 100. And there is also a therapeutic dose range as well. In terms of side effects with the tricyclics, we tend to see a lot more of these antihistamine type of effects. And then on top of it, I also listed here weakness and fatigue as another common symptom that we'll see. Desipramine is another one. This one is not on the $4 per month formulary, so this is one that I would not expect us to really see our populations use as much. But again, you can see that we tend to start at a pretty low dose range, and then we tend to need to have a much more higher usual dose. And again, with all these tricyclic medications, in terms of that side effect profile, these again are like the ones that I mentioned before, where they can cause cardiac arrhythmias, where they can interrupt your heart rhythms if they're at high enough doses. So, so probably for safety reasons, it doesn't make sense to use these as the first line agents, but at some point, as we're working with our patients, if we find that certain medications are not working, it's okay to use these, but we would probably not suggest them to be the first one to start with. So I don't know if you want to.
Oh, yeah, sure. Okay. So how do you choose an antidepressant? I think you go by a lot of ways. You might ask patients what's worked for them in the past. So what's worked for them in the past will probably work for them in the future. What works tends to run in families, so you might ask, well, if your mom or dad or your brother or sister had depression or anxiety, which medication did they use? Did it work? Did they like it? Because sometimes the effects, the beneficial effects runs in families. You want to ask patients what they want. When patients come to me all the time, and go back to the Coca-Cola analogy, these are different kinds of, these are like colas, especially the SSRIs. And they're more similar than different, although they do have differences. And unless there's some huge overriding reason, I let people choose what they want if there's no financial barriers. And I explain the financial costs to them. The expertise of the prescribing provider. Some of the doctors may not feel comfortable with one thing or another. So, if you're called to make a recommendation or say these are the options, doctors, they're like anybody else. They'll rely on the one or two things they know in a particular class and prescribe it all the time. So, doctors, if this is the only person available, don't try to necessarily push them to something they don't necessarily feel comfortable doing without consultation. Side effects, sedating or activating. So some medications like the tricyclics are definitely very sedating. Wellbutrin, for example, can be, it's quote-unquote more activating, meaning it can make people feel a little bit anxious or nervous when they first start it. Safety and overdose. TCAs are not good for people who are always suicidal because 10 days of it can be lethal. SSRIs, as far as we know, you can take probably a gallon of it, and it won't kill you from the effects of. You could take a bucket of it. You will feel very bad, but you will not die. You will not die. It sounds like a joke, but actually that's something very important to take into consideration if someone's suicidal. Availability and costs, and I think in this population that's a big deal. Like I said, I work with a lot of people who are transient, who are homeless. A lot of young adults who may or may not have homes. And I actually last week I saw one of the young men. He's a young man who emancipated from the foster care system, is transiently homeless, lives with his various friends, motels. And I started seeing him about a year ago for depression. He's 19. And actually I think what made the difference for him was the fact that he has no insurance. For some reason he lost his Medi-Cal. And I think the big thing that made a difference for him was getting something that was affordable. So we got him citalopram. And he goes to Target, picks up his $4 prescription, and he's able to do it every month. And so he's actually started getting really well, and as a result of getting well, he's been able to take advantage of lots of opportunities. But $4 a month, and he actually gets 3 months at a time now, which is $10, which is, I think, quite affordable. Drug-drug interactions, I think, with the younger people, you're not going to worry as much. With the older people, like Michael was saying, you want to pick what they call cleaner drugs that don't have as much drug-drug interaction, like citalopram or escitalopram. Maximum therapeutic dosages. These I'm not going to go into these in detail just because you have it referenced, but there are maximum therapeutic dosages. Yeah, so for the tricyclics, you can actually check serum levels generally 12 hours after the last dosage, so you can remind a doctor to do that. It has no relationship to whether the person gets better necessarily, but it can explain side effects, and it can also be used to check to make sure that someone is not taking more than they should. Or even taking them. That's a good point. That's right. Especially with the older people or younger people, anybody. But yeah, I mean, I think it's most people, it's so rare to see somebody on these medications for depression. I see it for incontinence or for sleep, but I rarely see it for depression. But I think, and generally the people who prescribe are psychiatrists, right, at this point. Yeah, exactly. We went through all the common side effects. The sexual dysfunction, actually, I think it's even higher than that, especially for the SSRIs. It can be up to 50%. We can go through that. Managing side effects. Consult with a prescribing provider, team psychiatrist. Are side effects physical or psychological? Well, it's really tough. Like, because I work at a DMH facility, I have to read the Riot Act to people. I have to go through every little, I feel obligated to go through every little thing and write it down. Like, you have headaches, GI upset, you get fatigue, you get X, Y, or Z. And not to say that people are, I feel like people really do feel these side effects. But I think because you're depressed, one's cognitive perception of every ache and pain is magnified about 1,000-fold. And it really limits people's ability to tolerate their physical conditions, I think, for lack of a better word, and to tolerate side effects. So I think it's both physical and psychological. Generally, the way I try to work with this is I, do the weight and support, right? Meaning, if you write it out, it'll pass. The second thing I do is I always cut it back. In other words, I go down by half. So if they're on 10 milligrams of Prozac, I'll go down to 5, especially when I'm starting. And I go up much slower. And like I said, if I do something where there's a liquid available, I will start them on like a drop, and increase by a drop every week. Because really the goal is adherence and long-term adherence, right? And make sure that you get the person on board for a long time. And if that's what it takes, that's what it takes. Temporary dose reductions, you can treat the side effects, and we're not going to get into treating the side effects because that's probably beyond what's going on here.
Is there a drug of choice for the jitteriness?
What?
Is there a drug of choice when they have the EPS?
The EPS? You probably want, if they start having EPS, you want to cut the medication down by half, or you want to just switch to another medication altogether. Especially a depressed person who has jitteriness and anxiety caused by EPS is not a good thing. It's very anxiety provoking. So that's what I would do. Change to a different antidepressant, or change to, hopefully, you'll have the option of doing cognitive behavioral therapy if you take part in this study. That's actually a really good, especially for things like special situations. Pregnant women, for example, right? So a lot of pregnant women may not want to take these medications, or women who are, lactating. So this is actually a pretty good illustration of the effects of antidepressant treatments. Actually, you got a question?
My
Yes.
question is, sometimes I see people coming in for treatment and they're on like 2 and 3 antidepressant medications at the same time. Is that indicated, or?
Well, the question was
do like one at a time.
So the question was more than sometimes this particular individual sees people on 2 or 3 antidepressants at one time. Is this indicated? What I would say to that is that it's hard to answer your question without having to see each individual cases. There are people who have chronic depression, or what we call treatment-resistant depression, who may not respond to one medication or even a second medication, but only respond to combinations of medications. And there are individuals out there like that. They're a smaller percentage than the people we're talking about in this particular educational panel. That's a whole different talk. Yes.
How long do you see patients usually staying on the medication? Is there a prescribed length of time?
Yeah, so we'll get to that in just a little bit, but essentially what we do is, we want to make sure that first of all, patients' symptoms get better first, and so we will keep pushing the medication doses to the maximum therapeutic dose range, and then if that's not working, we're going to switch. We would suggest switching to another medication until we finally get to the point where the patient is getting better. And so one way to check if the patient is getting better is to look at their PHQ-9 scores, and one way that we often will tend to consider somebody doing a lot better is if the scores are halved. So if they were sort of around 20 or something like that they're around 10. And we generally are looking for scores below 10 for patients to really be, feeling a lot better. At that point, it would be reasonable to keep patients on a maintenance regimen to maintain and consolidate, all the gains that they've made and keep them on that same medication for a period of about 6 months or so. So sometimes we'll go a little bit longer, 6 to 9 months, but essentially that's what we would call a maintenance phase, keeping them on that same medication, making sure that they continue to do okay. And then at that point, it would be reasonable to start weaning them off of the medication to give them a trial off of it. Now, not everybody does well when we go through that period, as you had asked before. Sometimes we'll find that patients, as we start to decrease the dose, they don't feel good. They start feeling depressed, or they start experiencing other side effects. And at that point, it would be reasonable to, push, rather than keep them at that dose that you just reduced them to, put them back up at a higher dose.
I'll make a comment.
Oh, sure.
So actually, the Agency for Health Care Quality and Research, which is a federal agency that assesses, does what they call quality of care research, which is kind of what we do, recommends their recommendations based on long-term epidemiological studies is that if someone has one episode of depression, it's their first episode of depression, they get treated, that they should be on an antidepressant for at least 1 year, for a full year, after their symptoms resolve, right? If they've had their second episode of depression, right, they recommend like 3 years.
It's a lot longer.
It's a lot longer. And from resolution, not from the time you start, but the resolution. And what they recommend if you've had 3 episodes is indefinite. So.
Nice for the drug company.
Well, I mean, I think so, but I think that it's I'm not an internist, but I think it's like any chronic illness, right? I mean, I think that if this is the one thing that helps you, it's like high blood pressure, right? I don't treat people with high blood pressure anymore, but certainly I remember if you took someone off their antihypertensive and they were running like in the 190s when they're supposed to, and actually with the medication they're running in the 130s, and then you take them off, boom.
I think that's why the treatment is so important along with it.
Yeah.
Because so many clients can also, in my experience, become emotionally addicted to the meds. And when they start to feel that it's being cut back, they start experiencing the symptoms because of some emotional tie to it.
Sure. Well, because, we all understand that, people, feel strongly tied to a lot of things, right? I mean, that would happen for any of us, right? If we got used to doing something, got out of our daily routine, we would feel a little discombobulated. But I think that by working with the patients, letting them say, okay, well, you're experiencing these symptoms. Let's go back up. We'll take it a lot slower. I mean, we can still work with them, and usually when I've had patients who have had those sort of symptoms, when we're weaning them off, usually we're able to get them off. If again, as Bowen mentioned, if this is sort of their first episode, again, it's a lot different if we're talking about people who have had multiple episodes of depression. That's a very different case. The other thing is that, in terms of those patients who need to be on, for much more extended periods of time, again, in terms of the drug companies making money, if it's $4 a month, it's not like they're making that much money off of it. I think that the main thing is that we're really looking for, are we doing right by the patient? And if this is the thing that's working for them, great. If it turns out that there's some other modality of treatment that's even cheaper, that'd be even better too. I think that the main thing is that we want the patients to ultimately, be back functioning, part of the rest of our society doing well. So, I think was this all? I think that the main thing that we just wanted to say with this slide. So going back to the slides here. the main thing that we just wanted to mention was that most of the side effects that we talked about, particularly for the SSRIs, people will experience them early, but they do tend to fade over time. As people, as their bodies get used to taking this medication, they start experiencing them less, with the exception of the sexual side effects. But as these side effects are going away, things start getting a lot better. If they're able to take this medication and it's working for them. So this is the reason why when we try to work with patients, we want to encourage them to stay on medication, because the most common thing I hear about from patients is, I started taking this medication and my stomach started hurting, or I experienced some diarrhea, and I decided this medication is causing problems, and I just stopped. That's not what we'd like to see, because we know this is what happens when people take their medications, that these side effects will eventually dissipate and go away over time, but they'll get better. So we really just want to try to encourage them to stay on it, to give it a try for about 6 weeks, 8 weeks or so. At some point, if they're still experiencing these symptoms after that point, if it's not getting better, maybe we need to switch. And at that point, it would be reasonable to work with the doctor or the prescriber to try something different. So again, with the sexual side effects, we did talk about this earlier. We know that for people who are depressed, again, they may be experiencing low libido, poor sexual function. So sometimes things will get better, but we do also know that these medications, particularly the SSRIs, can cause sexual dysfunction. So what we often will try to do is we'll see what will happen when we try to reduce the dose, see if the symptoms improve over that. Again, we might switch to a different medication or just even augment. And so this gets back to the question earlier about sometimes why are patients on multiple medications. And so sometimes we're doing it for a reason, and it's good to try to explore to make sure that there's a reason for it. What is probably not, what would not be okay is, if we're sort of mixing and matching medications in the same class, that's something that so somebody's taking Paxil and taking Prozac and taking, that doesn't make a lot of sense, because they're all doing the same thing. Sometimes, again, we'll augment with a different type of medication, Buspar or Buspirone, which is often used for anxiety. And then for patients, sometimes we will start using medications for sexual dysfunction, such as like Viagra or some of the other medications that we see ads on all the time. But if patients need treatment, we'll work with them to try to get them through it. But there are many different strategies. And so, when patients tell you that this is a problem that I'm having, it's a real problem, but there are things that a doctor can do to help them with it. I think we talked about this already in terms of the black box warning for SSRIs and the risk for suicidal behaviors. And really the big thing is close follow-up. And this goes without saying for anybody, regardless of whether or not we're worried about the black box warning for young adults. But the main thing in the collaborative care model is really making sure that there's close follow-up, that patients don't fall through the cracks. And from my side, in the doctor's office, we only see what we see coming in. And once the patient is outside, we still are concerned about the patient, but it's a little bit harder, to remember that, to check up on the patient. It's not always easy to follow up with them, and so that's the reason why it needs to be a team approach to make sure that we know what's going on with the patient. Not only us, when they're coming to see us in other venues, but also to work with their families as well, because we're the ones who are seeing them. So this is something that also came up as a question earlier. Do some patients respond differently to medications? And we do know that there are differences in terms of how people respond to the medications. So African Americans and Asian Americans can experience side effects at lower dosages than Caucasian patients, largely due to the way that they metabolize the medication. So there's a system called the cytochrome P450 system. Basically, most of our medications get metabolized in our liver. It gets broken down there. And so everybody's system is a little bit different, and these are things that developed over time. So genetically, we know that there are differences. So people may respond slightly differently depending on their background. I think that the main thing is that, for patients who are experiencing those sort of symptoms or coming from these groups, you probably want to start the antidepressants at a lower dose and titrate slower. But you still want to make sure you're titrating up. We don't want to keep patients at low, ineffective doses. That's the one thing that we want to avoid. So this is something that we referred to earlier. There was a trial that came out recently called STAR-D, which was sort of sequential treatment for depression, and they wanted to see what happens when we start patients on medications. And then, we all know that not everybody, the first antidepressant that is used is not always going to be the right antidepressant for individuals. So how should we go through, treating patients was the goal of this study. And so we know that in terms of people getting better, we know at the first step, a little bit more than half of the people, get better. Or a little bit more than a third get better, not half. So 36.8%, right? And then, so at some point, with that first step, that suggests that 2/3 of the patients aren't necessarily going to get better with that first trial of medications. So at some point, you need to consider additional steps. So each of these steps tells you that some people continue to get better, but again, there are people who are who don't respond even as we're switching medications. So it's not as though we can say that a patient is always going to get better by using medications. And we do need to go through multiple trials sometimes for some patients to try to find what's going to work best for them. But again, you can see that this remission rate continues to decline at every step because these patients are just more resistant to treatment than those people who responded earlier. And so we also know that those people who needed to get down to these different stages in terms of treatment also had higher relapse rates as well. So again, we know that there are people who are just not going to respond as well to these medications. And these were not just people that were on those SSRI medications that we talked about, but they actually went through and used some of these other antidepressants. And they, for some of these patients, they used augmentation strategies where they were on multiple antidepressants at the same time. For some patients, they were allowed to use psychotherapy. So again, we know that not everybody gets better. Again, recovery is the rule. Most patients will eventually get better. And even those patients who don't get treatment, at some point, they might get better too, although they're, again, more likely to go back into relapse and, have depression again if they're not treated. So the thing is that we can get them better, and we can get them better sooner than if we just left them alone. But there are going to be some patients who don't improve. So I guess I can go through this if you like. So in terms of, sort of good decision points in terms of treatment, so let's see. So I think, so this is just sort of an example of what might go on with a patient. So if in the first couple of weeks, patient, if we took their PHQ, if we did the PHQ-9 with them, they're scoring an 18 at this point in time. And the patient, and let's say the client comes back to your office and says, I didn't go see the doctor, but I stopped the medication. I just felt like it wasn't working for me at this point. So, here, there are problems that might, if you ask the patient why, they might give you a couple of different reasons why they stopped the medication. They might just tell you, I just couldn't take it for whatever reason, or they might say that I'm feeling a little discouraged. I'm not getting better immediately. I was expecting that as soon as I took this medication, everything would be better. Or they might say, I'm experiencing some side effects. I'm having some stomach problems as I'm taking these medications. I think that the main thing here is that, if you were going to work with a patient, you probably want to acknowledge their side effects, as we mentioned, if that was the problem. Acknowledge that they're occurring, but let them know what we often see with these sort of medications, that these side effects will get better over time, and that we'll start seeing that effect in terms of them getting better with medications also over time as well. So if they stay on the medication, if they're able to be patient with it, we're likely to see a better response. Another thing would be changing the dose. If it turns out that the side effects are really a real serious problem, maybe we just need to change it. If we started, let's say, at a higher dose, let's say we were starting at 20 milligrams of fluoxetine or Prozac, cut it back to 10, or suggest to the patient that maybe they should ask their doctor about this. And again, I think that the main thing is communication between everybody who's working with the patient, because sometimes when I'll be in the office and I'll see somebody come in, and all of a sudden, as I ask them about their medications, I find out, oh, you stopped the medication, or oh, you're taking more, and so I think that the main thing is letting everybody know, because it's a team effort, and I think that the more everybody knows, we're going to be able to work with the patients best. And then patient education as well, letting them know what to expect from the medications. Again, adherence problems, as we mentioned, should they take it in the morning, at the night? I think the main thing is what works best for the patient. Sometimes, so let's say, after the 4th week, the patient's on, let's say, fluoxetine 20 milligrams, as we mentioned before. PHQ-9 is still 16, when we rechecked it. Basically, hasn't been much of a response. And so at this point, it would just make sense to go ahead and just start increasing the dose. If we're not really seeing much of a response, we would expect sort of around by week 6 or so that people are really getting better, and this is not really much of a change. As we talked about earlier, the PHQ-9 can fluctuate. So, really moving from 18 to 16 is not that big of a change, and so it would be reasonable to change the dose and increase it up. As we mentioned earlier, for using a medication like fluoxetine, that therapeutic range is going to be somewhere between, let's say, 10 to 60. So there's certainly room to increase the medication and still do okay. So let's say the doctor was notified and the dose was increased to 40 milligrams. Patient's PHQ score is still 15. Basically, we're not seeing much of a response. It's been 8 weeks now. I've been 2 months on this medication. This is a pretty reasonable dose. I mean, we could still try increasing the dose up to 60 milligrams, but at some point, you've got to say, is this really working for us or is it not? And it would certainly be reasonable at this point to say, well, this doesn't seem like it's been working for you. Let's try a different antidepressant.
So let's say somebody is at week 8 and they're on 40 milligrams. They're actually doing great. They got a PHQ score of 4. I'm not sure I have a PHQ score of 4 today. I might have a little higher. Actually, this morning it was probably like a 10. But now I'm about a 3. But let's say their problem was anorgasmia, which is, not so pleasant. A good thing to do would be to switch it to another medication. I'd actually probably just add another medication because I hate to mess with something that's working, if at all possible. So I'd add like mirtazapine or Buspar or even actually bupropion. There's other fancy things that you can do, but since you're not physicians, I'm not going to go into all the details.
Physicians know that? Because I'm feeling like...
Some physicians do, some physicians don't.
Some do, but most primary care doctors
don't.
Do not feel comfortable.
Yeah, they don't know that. I think most psychiatrists would feel comfortable doing these things, and they do things like prescribe Viagra. I mean, some of them actually prescribe like methylphenidate, like low doses, but I don't recommend any of that. But I'm not, but those are some of the tricks that people do. Partial responders, let's say they have PHQ score 9 of 10 and they're on 40 milligrams, you just want to increase it or add CBT. That's always an option, doing more therapy. Yes?
I was just curious about how, like you mentioned about, pregnant women and obviously there's choice of, patient choice involved whether to do CBT and or medication therapy, but do you have other kind of heuristics, rules of thumbs, considerations about when you might want, to switch someone to CBT rather than...
Well, I mean, I think the reality is that CBT doesn't exist for most of the populations that we work with. At least that I actually am lucky because I'm at Harbor, which is a teaching hospital, and they do have CBT. But I know it doesn't exist necessarily in most places. I mean, that's hopefully one of the goals of this study is that we can enhance capacity around.
Would you say ideally it would be great if people got both?
It would be ideal if people got both, and people, the studies seem to suggest that people who get both do best. But with CBT and medication, depending on which study you believe, they work about the same. Maybe CBT works better longer than medication. But yes.
What about acupuncture?
The question was acupuncture. Actually, the studies on acupuncture have been they're hard to assess, meaning that there have been a number of studies on acupuncture. The best studies have actually been with pregnant women in acupuncture, because that's it's hard to do a study on using a modality if you don't have a condition that is, especially if you have an effective treatment. So the one group that they tried it on was acupuncture, because there's some concerns around, this was a couple years ago, around whether the medications affect development and all that. But they were equivocal because it's hard to come up with what they call a placebo for acupuncture, right? And so it's hard to really test it. So the studies have been very equivocal, meaning that it's unclear what to make of the results.
What about herbals? I know a lot of our patients have St. John's.
St. John's wort, that's a very good question. St. John's wort has been shown to work in some studies and shown not to work in other studies. In general, I think that it probably doesn't work as much as we hoped it would. A couple reasons why. One, because herbal medications, by law, there's no consistency. So what you get from one place, or even so, what you get within a bottle, what is called St. John's wort, what they call the bioavailable equivalents of each pill, there is zero consistency in any of those pills, right? In the drug studies, in the herbal supplement studies, they actually, because it's a study, they had equivalency. So even in the best situation, there were a couple studies that were positive, a couple studies that were negative, but it basically showed that it wasn't clear whether it worked. So if it doesn't work in the best situation, it's probably really not going to work in a situation where you're not clear exactly what you're getting. I like to tell my patients when they come up with this question is that there's no bioequivalency. I mean, actually, my background, my family is very much into acupuncture. My mother is first generation Korean, acupuncturist, herbal medications. So I've grown up with that. I get that, right? But on the other hand, it's like literally billions of dollars have been spent sometimes developing some of these treatments, and some of them, and they're not perfect, but they generally work fairly well, especially these older ones. Remember, there are a lot of medications, 20 FDA-approved medications. Most of them are very effective in about 50% of patients. You may have to try a couple things, and actually, we say that lightly. We may have to try a couple things until something's effective is found, but that can be very frustrating for people because that could be a couple months. That could be like 6 months until you find something that works. And I think the job of a lot of people, especially the care managers, is to be a coach, right? To be kind of like a cheerleader from the side, this is really frustrating, but really going to find something that works. If you have access to CBT, I think that's great. You should really try to use it. And if you get involved, get more actively involved in this study, figuring out how to adapt education and cognitive behavioral therapy approaches to your particular setting is going to be really important. But even with the therapist, let's say they go from a 20 to like a 12, and the medications aren't working. If they go on the third one, it might get them down to a 4. Let's see. If medications are not effective at a therapeutic dose, make sure they're taking it. Mike says consult with a prescribing prescriber, meaning make sure that the prescribing provider even knows that because there's not a lot of communication even in primary care clinics, as we all know. If you have access to a psychiatrist, on the more difficult cases where people don't get better, you might want to save all your cases for those people so you conserve resources. Give, quote unquote, the simpler cases to the primary care provider. Let's see. And if people don't respond, you want to do all the things that we talked about. Change the treatment plan. Most people need changes. I mean, it's treatment adjustments. As we said before, only less than half will have a complete response on the first time around. What is Plan B? So we've gone through this very quickly. For partial responses, augment with another medication or psychotherapy. Switch to psychotherapy or another medication. I generally do both. Combination therapy, also considered combination therapy. Augmentation will also I'm actually specialty mental health, but sometimes I do get referrals from primary care, so pediatricians or internists or family practitioners, where they sort of consult with me. So if you have access to any mental health resources, I think within this study we're going to try to figure out how to make that happen. But you may want to ask about your, like St. John's, for example. I love your clinic, and I'm very familiar with it. But maybe there's some way to provide a resource like 2 or 3 hours a week where you could hire a psychiatrist where they could work on those sorts of things. ECT is not an evil thing. It works really, really well, especially for people who don't respond to any antidepressants whatsoever. But this talk is not about ECT, but it's very safe, it's incredibly effective, and the big side effect with it is memory loss. But people do incredibly well with ECT.
Is it readily available?
Yes, it is readily available. Yeah, except for adults, it is. For kids if you're a kid, you can't get it. I mean, you need like a court order. Even then, I'm not sure you can get it. So. Let's see, one more. I'll do one more and then go. You can go. See consultation with a psychiatrist if they're really, really bad. I mean, they're just not moving. You know the type, they don't bathe, right? They're, like for days, they're just sitting in their room, right? They look like they can't move. They're practically catatonic. They whisper when you talk to them, right? They fail to respond to treatment at all, first, second, or third treatment. If they have a personality disorder, and you know what? I want to be careful about personality disorders. People who are depressed and anxious are irritable. They can be ornery. They can split, right? And when they're better, they're fine. So be very careful about personality disorders. Substance use, though, is a big deal. So if they're using speed or opiates or lots and lots of alcohol, you may want to get some consultation on how to manage that. Bipolar or psychotic, that's obvious. Is suicidal or homicidal? I think that's obvious. You want to go.
All right, so this is where we talked about risk, when to stop antidepressants, something that we've already sort of talked about. And I think that the main thing is that we really want to reduce the likelihood of people relapsing, because we know that the likelihood of somebody having depression again, if they have a major depressive episode, is pretty high. Right? So we know that the risk is 50% if they've had an episode of depression in the past. So half of those people who've had depression in the past are going to have depression again. It's even higher as they've had multiple episodes, as you can see here. By the time that they've had 3 episodes, it's pretty likely they're going to have a 4th one. And we also know that the risk of having depression is also higher if they also have dysthymia. Again, if they have sort of that low-level chronic depression-like syndrome, or if they have residual depressive symptoms. And again, this is where we get back to that issue of, recovery is the rule, but, so you could get better and you might not take the medications, which is part of the reason why with some of these studies it suggests that they might be effective, might not be, because people do get better, but they often will have these residual depressive symptoms and they won't really get all the way better, and then they'll more likely have an episode down the road. So, so we definitely want to make sure that we prevent that from happening. But we also don't want patients to be on medications all the time. Nobody wants to take a pill for the rest of their life if they don't have to. So again, we generally want to, first of all, get that initial response. We want to make sure that patients get better first. Once they're better, then we can keep people on the sort of maintenance dose, make sure that they're on a good, that they're doing fine for a good set period of time. So, as I mentioned, I generally tend to do sort of 6 to 9 months. A year is fine as well. And probably for the populations that we'll be working with here, they probably do need to be on longer than just sort of, 4 to 6 months or something like that. They probably do need to be on a bit longer, because many of them are going to fall into these other categories where they've had prior episodes of depression in the past, unless we're working with younger people who haven't had an opportunity yet to have depression. So we also want to treat those who are at high risk for relapse for 2 years or even longer, as we mentioned, potentially indefinitely, for some of these people who have frequent episodes of depression. And as we mentioned earlier, some people may need lifetime treatment. But the main thing is that we want patients to be better. That's the ultimate goal. And of course, people always say, "Well, I don't want to take a pill." But on the other hand, when we see what they're like when they're better and when they're worse, I think that it's often not that hard to work with patients in terms of explaining to them what those differences have been and why it's really important for them to stay on treatment if they need it. Maintenance treatment should be at full dose. You don't want to, just because they're doing better, you don't want to start cutting things back, because you're likely to push them back into depression again. And I think that the main thing is you want to work with them in terms of a relapse prevention plan. So we know there are certain things that might make things worse. So we want to try to avoid those triggers. So as we talked about the cycle of depression, if we know that there are certain things that tend to make people worse, or for example, people who are have substance use disorders, if we know that drinking is a problem for them, we want to try to minimize that and work with them on that and stop the disorder. And then finally, we do want to taper slowly, because again, people do experience some of these problems in terms of coming off of the antidepressants. And I think that the main thing is, if they're experiencing some problems as we're trying to discontinue the medication, just go slower. Key things that we usually like to tell patients is that, how do these medications work? The main thing is, first of all, they're not crazy. That's usually the main thing that we want to tell patients. This is a disorder, and it's treatable, but it's not. But they're not crazy, and we know that with these medications, they work on changing some of these chemical imbalances that develop in our brains. And the other thing is that we also know that there are many options available. So if something is not working for them, or if they're concerned about this one medication, I heard my friend took this medication, caused all sorts of problems, they don't have to take it. I mean, there are other options out there. We all know that patients have a lot of concerns about taking medications, largely because of issues of stigma. If somebody knows that they're taking an antidepressant, they're going to be labeled. They don't want that to occur, so so they end up in this sort of response where they say, because I don't want to be labeled as having depression, even though they have it, they won't want to take the medication. And I think really working with them in terms of explaining to them what the medications can do for them, and where they can be if they get appropriate treatment. Is the main thing. And then, the other thing is offering alternatives. Again, for some patients, psychotherapy really is better for them. Some people respond better. And again, there are people who don't like to take medications, period. And we understand that. And so if psychotherapy is an option, by all means, I generally try to recommend that for patients if they are uncomfortable with medications. Side effects, these things do happen, and it's important to know about them and to let patients know. So if you're seeing, let's say, a patient and you're going to send them to a doctor and they acknowledge that they have depression, let them know that sometimes there are problems that occur initially when you take the medications. And some of these common side effects, such as having stomach problems, they might feel a little bit nauseous, they might feel a little restless with some of the medications. Let them know that these things do happen. They often happen initially over the first couple of weeks, but they often get better. And let them know that you should try to give the medications a good try for several weeks, and those side effects will probably get better. But again, acknowledging those concerns and making sure that there's some way for those patients to let people know that they're experiencing it, so that we can work with them on it or to manage those symptoms is really the key thing. And then the final thing is, again, adherence, which kind of feeds back into the side effects. The main thing is making sure the patients can take the medication. So as we talked about earlier, it's great if we can optimize the medications, but the main thing is that we want to make sure that the patients are taking it on a consistent basis. And then we really want to make sure that patients don't stop when they start feeling better. Again, just like all of us, at some point, it's not just with antidepressants, it's with any medication. So if we're taking antibiotics because we were sick enough, our doctors prescribed it for us, by the time people start feeling better, they usually will just stop the medicine. Even though we will generally suggest, whatever course that we've suggested, a week, 10 days, 2 weeks. The most important thing is making sure for antidepressants that we stick with this maintenance phase of treatment, so that they really consolidate the gains that they've achieved, and that we can finally take them off and will minimize the risk of relapse. This is the last slide. Yeah. So I think this is, again, sort of the same thing in terms of emphasizing adherence. The key thing is making sure they take their medicine on a daily basis. I mean, it is possible to get away with something like Prozac just because it has a long half-life, and so the drug company that makes Prozac, has this long-acting formulation now because they know that it has a very long half-life. But the most important thing really is to emphasize taking it on a daily basis, so that they'll be able to continue to get the effects over time. Again, waiting 2 to 4 weeks for an effect. If you're talking to a patient about these medications and they're saying, I'm not feeling so good with these medications for all the reasons that we talked about, encourage them to stick with it. Just give it a month. See how you do with it. And then, as we mentioned, side effects can occur, but they often resolve in a couple of weeks. So again, this is sort of the reason why, telling patients to be patient is really a key message. Keep taking the medication even if you get better, just as we mentioned earlier. And then checking with the doctor who prescribed it, before they stop, because, again, it might be appropriate for them to stop the medication. As we mentioned before, one of the common problems we see in primary care is that patients continue on these medications for several years when they didn't need to be on it for several years. There are some who need it, but not everybody does. And then the final thing is, again, sort of along the lines of making sure that we reinforce with patients, the common sort of misconceptions. First of all, they're not crazy. these medications are not addictive. They can experience some problems as we start taking them off of the medications. But again, we usually can work with them and get them off of the medications completely. So I think that these are sort of the key messages that we usually like to let patients know and providers know so that they can help the patients understand their medications better. So we're at 3 o'clock. You guys have been very patient, so thanks for sticking with us.